Hi, this is Dr. Shannon Da Silva. In this presentation, we'll talk about ultrasound, documentation, and pitfalls. So this is your pro tips ultrasound presentation. All right, so we're gonna jump into low-lying placenta. So it is important that when you are looking at the placenta that you look with a longitudinal scan. The bladder has to be full. And you want to make sure you can identify the bladder. You're also going to identify the placental margin, the lower uterine segment, and the cervix. And so you can see in this image, all of those are identified. It is important to measure the internal os distance, which is labeled IOD here. And so it is measuring from the edge of the placenta to the cervical os. If it is greater than 2 centimeters, it is not low-lying anymore, and that patient can deliver vaginally. But if it is less than 2 centimeters, that's going to be, depending on how close it is to the placenta and the situation in the hospital setting, it can be a patient-shared decision-making model on what will be done. There needs to be a physician or a surgeon available if there is an emergency. All right, so now we're going to talk about crown lump length. It is important when we do ultrasounds that we measure appropriately, that we are correctly identifying the gestational age is what we're determining with a crown rump length. We want to have a midline sagittal section of the whole embryo and fetus. It should fill the width of the screen so you can zoom in so that you can see the fetus really well. It needs to be in a neutral position so you can see that first image. The baby is just neutral. It's not flexed. It's not hyperextended. And you want to measure from the crown to the rump of the baby, rump meaning bottom, where it is clearly defined. So you want to make sure that you can see the baby well. And then you want to avoid inclusion of structures like the yolk sac. Sometimes I actually saw an image where somebody measured from the top of the baby all the way down to the bottom of the yolk sac. And so obviously that is going to skew the gestational age significantly. And so we want to make sure that it's done correctly. We want to see the amniotic fluid visible between the chin and the chest. So you can see in the second image, the baby is flexed. You can also see that the end of the measurement on the rump, it doesn't quite go to the rump. And then again on the last image, the incorrect image, it's not getting the full baby in the image. You can't see the legs, you can't see the rump well. And so those are not going to be correct dating ultrasound. So it's very important. This can be very hard because the baby's little. It's hard to get that perfect image, but it's very important when we're trying to make decisions later that we have a good ultrasound at this point. So another one that we want to talk about is an ectopic. Let's see if we can watch the video. So in the video, you can see it is a cine. So it's scrolling through the, using a longitudinal scan where it's scrolling through the uterus over to the ovary, and it identifies an adnexal mass with something in there. And if you look closely, you can see actually a little tiny fetal pole in there. The other image on the screen shows the ring of fire, which is using a color Doppler to look at an adnexal mass. You can see the ovary right next to it, and that shows that there is blood flow to that mass, and it also shows a little tiny fetal pole inside. So it is important that you document what you see and where you see it. Is it on the right? Is it on the left? Is there free fluid? Make sure you identify key structures. Is there a gestational sac? Is there a yolk sac? A fetal pole? Is there cardiac activity? Because that's going to determine what you can do. So if you can do methotrexate or if they need to have a surgical intervention. It's important to record objective measurements. So measurement of the crown rump length, fetal heart rate, making, and then saying your impression. So you can, if you see a uterus and if you see a pregnancy, an intrauterine pregnancy, put that. If you aren't sure about an ectopic, you can say suspicious ectopic. If you can't see anything at all, pregnancy as unknown location. And I always recommend that you have a second person do an ultrasound. Especially if the uterus is empty and you're still learning, have somebody that's more experienced come behind you and do an ultrasound. So when we're documenting an ultrasound, so often this is one of the challenging things as we go from our transition to being a provider from a nurse. I just like to give examples of documentation. So you could say, this is an adnexal mass with an empty uterus. So transvaginal ultrasound performed, no intrauterine gestational sac visualized. Endometrial stripe is central and measures however many millimeters. Right adnexa contains a complex mass measuring, blank by blank by blank centimeters, with a hypoechoic, hypo meaning not as bright, and cystic components. So there's something inside of there, possibly consistent with an hemorrhagic cyst versus an ectopic. Mild free fluid noted in the posterior cul-de-sac, that's if you see it. And then you can recommend serial HCG follow-up imaging, or in this case, the patient would need to have an intervention if you think it's an ectopic. So we'll move on to fetal biometry. This means the growth. So when we're doing measurements of the baby. So we're doing measurements to assess fetal growth or dating. We must obtain the correct imaging and plane and landmarks for accuracy. So the common parameters that we look at are the head, which would be the biparietal diameter or the head circumference, the abdomen or abdominal circumference, the extremities, which we measure the femur length, and we use all of these measurements to calculate the fetal weight. It's really important when you're measuring the biparietal diameter and the head circumference that you have the correct image of the baby's head before you measure them, because this can greatly impact the result of your measurement. So the technique for doing this, you want to get a transverse section of the baby's head at the point where you can see the thalami and the cavum septi pellucidae. So in this image, you can see the thalami and the CSP, and then in the image below that, you can see that they are measuring the BPD and the head circumference while correctly identifying those structures. So when you're doing the BPD, in most cases, you would need to check with your sono machine calibrations. You're going to do the outer edge to the inner edge of the skull. When you're doing the upper to inner calipers, so the one that's closer to the top and the one that's closer to the bottom, you're going to do the outer edge at the top and the inner edge at the bottom. And then for the head circumference, you're going to do the ellipse around the outer perimeter of the skull. And so just a reminder, the head, you want to make sure you identify the CSP and the thalami before you do the measurement. When we are measuring the abdominal circumference, again, we will get a transverse section of the abdomen. You want to identify the landmarks. The stomach bubble needs to be on the left of the baby. The portal vein or the hockey stick or J-shaped landmark needs to be identified. The abdomen should appear round and not oblong. That could indicate that you're cutting into the baby with the sound waves at an angle. And then you should not see kidney or spines being cut through obliquely. You want to measure the ellipse around the outer skin line. And so you need to measure the skin because you are making, the baby could have more adipose tissue. And so you want to make sure you get that whole skin line. And so with the abdomen, remember stomach and the portal vein sign. So when we're measuring the femur length, so the femur, we're looking at the diaphysis. And so the beam needs to be perpendicular to the shaft of the femur, and we're looking at the femur diaphysis. So the epiphysis is on the ends of epiphysis is on the ends of the long bones, but we want to make sure we get the bright diaphysis. So the landmarks, you want to make sure that the femur is visualized horizontally on the screen. The ends need to be clearly defined. You do not want to get the epiphysis measured, and then you want to exclude the femoral head or trochanter. You want to measure the greater trochanter to the distal femoral condyle, so the straight bone portion. So you can see on the image on the bottom, you want to measure the very outer parts of that, end to end. So remember, for the femur, you want to think long, straight, ends visible. Moving on to a subchorionic hematoma. This is very common that you'll see. Patients will go to the emergency room and you'll see the patient following that, and they'll tell you that they have a bleed below the placenta, or they might remember the name subchorionic hematoma. Often, if you were to see it, you may write suspected, you may put subchorionic hematoma as you gain confidence, but I'll just go over the documentation that I would recommend. So typically this is seen with a transvaginal ultrasound, so transvaginal ultrasound performed, single intrauterine pregnancy with a positive cardiac activity, a crown rump length of however many millimeters equaling however many gestational weeks gestational age. Adjacent to the gestational sac, a hypoechoic crescent-shaped area is seen between the chorion and uterine wall. So you can see in this image, that is what we see. Between the chorion and the uterine wall, consistent with a subchorionic hematoma, measuring however many centimeters by however many centimeters. The cervix is closed and no significant free fluid is noted. So you'd want to make sure you measure it. Next, let's talk about the IUD and the correct position. So documentation of a correct position of an IUD. The transvaginal ultrasound is performed. The IUD is visualized as a linear echogenic structure. So it's echogenic, meaning that it's bright. Structure within the endometrial cavity, positioned appropriately with the arms at the uterine fundus. There's no distortion of the endometrial stripe, and the uterus and adnexa are unremarkable with no free fluid noted. And so you can see the lower two images, that is an IUD in the correct position. You can see that the arms of the IUD are visualized. You can see that the IUD is all the way up into the fundus, which is where it should be. In the images, the two images above it, you can see the IUD, you can see the fundus of the uterus in the first image where it has the uterine endometrial thickness. They're measuring it, and it also shows that the IUD is not in there. And then you can see lower, closer to the cervix, that bright echogenic structure, which is the IUD in the lower uterine segment, meaning that it is not going to be working correctly. And then you can see the other image showing the cervix, and you can't see the name, but it's cut off. It says cervix, so you can just see RVIX. And you can see the echogenic structure, which is the IUD that is in the cervix. And then the image on the top, it looks like the IUD is embedded in the uterine, the lower uterine segment. So you can see that it is poking through the endometrial stripe into the uterine body. So this would be something that would need to be referred to the OB-GYN to be surgically removed. So let's talk about twin pregnancy. So this is a dichorionic pregnancy. So this is just a way to document. I just like to go over documentation because, again, that's one of the things that we struggle with as we transition from nurses to providers. We're used to reading them, but we're not used to actually documenting. So if you do a sonogram, you need to document it. So a transabdominal ultrasound was performed. 2 gestational sacs were identified, each with a yolk sac and fetal pole, demonstrated cardiac activity. Thin separating membrane and lambda signs suggest diamniotic twin gestation. Crown rumblings measure however many millimeters and however many millimeters, showing that there are X number of weeks gestation. No abnormal hypoechoic area seen. Adnexa appears normal bilateral. If it's a monochorionic pregnancy, then you would say a single gestational sac with 2 fetal poles. Thin hyperechoic membrane noted between the fetuses, suggesting a monochorionic diamniotic twin. So I don't have an image of this one, but that would be a much thinner membrane. So let's talk about a common pitfall with missed ectopic. So a patient presented in early pregnancy with a positive HCG. A transvaginal ultrasound confirmed a pregnancy, and ectopic was not ruled out. Later, the patient was found to be, it was found to be a tubal pregnancy with a fetal pole and a ruptured ectopic. So what went wrong? The midwife mistook the adnexal mass for an intrauterine sac, and this actually did happen in a clinic, and they did not identify or confirm the double decidual sign, sac sign, or the uterine landmarks. That's why it's so important that when you are doing an ultrasound that you make sure, can you see the bladder? Can you see the cervix? Can you make sure that the baby is in the uterus? They failed to document a gestational sac location relative to the endometrial canal. And so it's always important that you confirm the pregnancy is intrauterine. Just because you see a baby and you see a heartbeat does not mean that everything is okay and you can go along your day. You need to make sure that it's in the right spot. You need to make sure there's not 2, and you need to use the landmarks. The adnexal scanning is critical in all pregnancy evaluations. And then if in doubt, get serial HCGs and rescan. Get someone else to come in and look with you if you're ever concerned about an ectopic or you're just not confident in your sono. So inaccurate dating, another common pitfall. So patient presents for an early pregnancy ultrasound based on a reported LMP of 6 weeks, 2 days. She has a history of irregular cycles, but states her last period was about 6 weeks ago. A transvaginal ultrasound is performed and an HCG is 950. There's no gestational sac seen, and the provider expresses concern for a possible pregnancy loss or ectopic. The patient is distressed and schedules an urgent follow-up with her OB. She has a repeat ultrasound 1 week later, and it shows a viable intrauterine pregnancy at 6 weeks, 1 day. Again, this is a real situation. And so that patient now has completely lost trust in her midwife. And so it is very important to know the correlation with the HCG and what you would expect to see in ultrasound. I know you don't know this now, but it's always important that anytime you do an ultrasound, you have to make sure, what is the whole clinical picture? Does she have regular periods? What's her HCG? What you're seeing just really early pregnancy, or is it a loss? And if it's a loss, do we tell the patient for sure it's a loss or an ectopic, or do we need to evaluate further? So the repeat ultrasound 1 week later showed a viable intrauterine pregnancy at 6 weeks, 1 day. So what went wrong? The midwife assumed that the LMP was accurate despite uncertain dates and irregular cycles. The ultrasound was performed before the HCG discriminatory zone, which is typically between greater than 1,500 to 2,000. And even ACOG says that using a discriminatory zone when you're possibly doing something to resolve the pregnancy above 3,500. So we want to be very conservative on our HCG levels before we tell a patient that they've miscarried. And in this patient, she wasn't bleeding. She didn't have any pain. So we can be more, have more observation and follow up with this patient. The patient received unnecessary alarm and follow up based on a non-diagnostic ultrasound. So the LMP alone is not reliable for dating. I mean, how many times do people just make up an LMP, or they aren't really writing it down, so they really have no idea. So just be careful about using the LMP to make a diagnosis. Avoid scanning based solely on the HCG unless symptoms require early evaluation. And then waiting, it might be advisable, or it should be advisable unless there's complications going on, to wait until the HCG is above that 1,500 or 2,000, and in some cases up until 3,500 based on ACOG just being extra conservative. Early non-diagnostic scans can create anxiety, mistrust, and unnecessary interventions if they're not needed. So it's that whole, making sure. I do like having a early dating ultrasound, but not too early. So you want to make sure that you correlate it clinically, and you can read more information on this in this article. So just kind of a review of general safety principles. It's important to perform a systematic scan every time. I always do my AFIs a certain way because that way I won't forget one. It's easy to get talking to the patient. It's easy to get distracted. Somebody comes in and asks you a question. The baby moves and you think it's cute and you want to get a picture. So I always do my AFIs a certain way. I always put the ultrasound on the patient a certain way, and I have a routine of how I do things, and I always look for the heartbeat first. So make sure you do a full sweep of the uterus and the adnexa and the cul-de-sac. Document the key findings: the gestational sac location, the yolk sac, fetal pulp, crown rumpling, cardiac activity. Look at the ovaries. Use a check when you're a new sonographer. Use a checklist. Make sure you're looking at everything. Have ways to remind yourself so you don't miss something, and then have a habit of pausing and reviewing before you stop the scan. Once the patient leaves, they're gone. And so sometimes you can call them to come back if you forgot to check on something or you forgot to look at something, but often they're not going to be able to come back. They're moving on. They have to, have something else that they're doing. And so make sure you pause and you think, have I done everything? Did I get everything I needed? And then normalize the second review or consultation. So don't feel bad to get another person to check, to get a second opinion, to send her to a MFM or your consulting OB-GYN if you have concerns.